Hello, everyone. This is Chadi Alraies from Riyadh Structural Heart in 2026. I'm really privileged with my friend, a colleague, and co-fellow back in general
That's right.
fellowship in the different programs, but different years, Akhil Narang, to talk about echo imaging for evaluation and also qualification for tricuspid valve intervention. Akhil, thanks for being with us.
Yeah,
Always
Chadi,
a
good
pleasure.
to see you again.
Yeah.
Thank you for having me.
Yeah,
Appreciate it.
great talk about tricuspid imaging.
Yes.
So it's becoming an evolving space, but it's a very delicate space as well. So tell us from your perspective as an advanced imager, uh, which patient you should look for intervention.
Yeah, I think you're right. It is an emerging space with a lot of technologies that are in existence and also will be coming under the pipeline soon. I think it's about patient selection. I think the right side of the heart is very unique in how the hemodynamics, the physiology, all coordinate together to understand how patients have symptoms and what their outcomes might be. And so, choosing the right patient for tricuspid interventions, I think, is key. We right now have options that are either valve replacement or TEER technologies. And obviously, they're very different in terms of how we approach these patient populations. I think generally the way that I think about things is we have to understand the anatomy of the patient, number one, right? So if the anatomy is favorable for one procedure or another, that's usually the first delineation. Secondly, we have to understand the big picture for patients. Patients who are able to tolerate longer-term anticoagulation might be better for valve replacements, provided that the hemodynamics are favorable. Patients who perhaps otherwise cannot get valve replacement, should be considered for TEER therapies. And so,
Yeah.
understanding that I think is key. From an imaging perspective, we also understand the right ventricle, right? I think that is probably the most important aspect of this that we underestimate. It's not just the severity of TR, but what's the RV function? RV function is hard to delineate, as we know.
Mm.
It's not just TAP CNS prime. You have to be thinking about strain, 3D echo, and then also the RVPA coupling. So if the pressures are elevated in the pulmonary circuit, will it actually benefit the patient? That
Yeah.
remains unclear. So it's understanding that complex balance of the imaging plus the hemodynamics and the patient itself to determine what therapy would be best for each patient.
Uh, what is the criteria, or just for a quick word about device-related TR? Is it something you should look for, or usually you guide the interventionalist to or EP colleagues to take the wire, keep the
Yeah.
wire?
It's a good question. I think early in our experience in tricuspid valve replacement, especially, we would think about taking the leads out, and I think that has become less of an issue. I think the more contemporary data shows that entrapping the leads in our right patient population is generally okay. There will be some instances in which the lead should be taken out and perhaps a leadless device should be placed, or if the patient needs the lead at all. I think that it is a multidisciplinary conversation in our lab. The way we do things is we have a heart team meeting that includes the electrophysiologist and understands the need for pacing or what the reason for the intracardiac device is, and what the risks are of entrapment,
Yeah.
if there's enough slack on the device. And that's for the valve replacement space.
Yeah.
In the patients who are undergoing TEER, it's less of an issue because usually if it's not valve or lead related TR, we can work around the lead to be able to impact and decrease the amount of TR. So it is a conversation. I think the patients have to be part of this as well, so they understand what the risks and potential benefits are for them.
Final comment on follow-up imaging. How
Yeah.
often and how frequent?
Yeah, early in our experience, I think the RV is, again, the thing that usually sees a decline in function, especially with valve replacement, less with TEER replacement. We do the standard imaging protocol where upon discharge, we image the patient. And we often do imaging at 30 days. I think one of the scary things are that people think that they can come off diuretics initially, and that can often, if there's some residual regurgitation, make things look worse at 30 days. So we never really change the medical management up front, maybe down the line. But I think beyond that, you do want to follow these patients regularly. If it's a valve replacement, you want to make sure gradients are not increasing. There's no paravalvular leak. If it's a TR, you want to make sure that TR hasn't gone up over time. So you do need regular follow-up for these patients to make sure that they're optimized medically and also from an imaging perspective.
That's great. Thank you so much, Akhil, again for a great overview from imaging as well a clinical perspective, how to evaluate and intervene on tricuspid valve. Watch the videos and others on the YouTube channel. This is Chadi Alraies coming to you from Riyadh Structural Heart 2026. Akhil, thanks again.
Wonderful. Thank you so much.